Welcome to this explainer. We are issuing an urgent clinical briefing today, and you need to listen closely. Our objective is to firmly establish a startling reality. Routine, asymptomatic medical screenings administered to patients over 60, and particularly those past 70, frequently induce severe iatrogenic harm. In many documented clinical cases, they can even be fatal. Consider this a life-saving medical alert regarding the hidden physiological risks embedded in what we call standard preventative care.
So what does this all mean? The crucial point is that the screening math completely inverts as we age. Look, at 50 years old, early detection makes mathematical sense. Your body has a high physiological reserve. It can survive toxic treatments, securing decades of additional life. But as we age, that biological reality deteriorates. An older organism operates on a vastly depleted reserve. Because of this, the medical priority has to drastically shift away from aggressively eradicating localized disease and pivot towards the careful, protective preservation of systemic stability, or in medical terms, your homeostasis.
In this briefing, we will systematically deconstruct the biological vulnerabilities of aging by covering the geriatric paradox, the lethal cascade effect, 5 high-risk systemic screenings, the symptom distinction, and finally a strict 4-question protocol to defend your autonomy.
Let's start with part 1, the geriatric paradox, and what happens when indolent cells actually outlive the host.
We have to recognize a fundamental biological truth about cellular aging. Many abnormalities and tumors detected in older adults have what's called a low mitotic rate, meaning they divide incredibly slowly. They grow so lethargically that they will actually never generate physical symptoms during the natural remaining lifespan of the patient. Simply put, the patient will comfortably die with the condition rather than from it. And this brilliantly, yet tragically, illustrates our greatest threat, iatrogenic harm. Because these conditions are indolent, the aggressive medical intervention itself, the biopsies, the radiation, the surgical trauma, frequently becomes the fatal pathology. Moving on to part 2, let's examine the lethal cascade effect and how minor interventions severely disrupt critical homeostasis.
Okay, let's trace this dangerous cycle. An asymptomatic patient goes in for a routine test. A minor irregularity is flagged. Instantly, this triggers an automated, almost unstoppable chain reaction. The finding forces an invasive biopsy, which confirms an abnormality, which then mandates major surgery, which inevitably leads to severe systemic complications. By treating asymptomatic seniors with intervention thresholds meant for 50-year-olds, perfectly healthy individuals are left permanently broken by the very medical system designed to protect them.
Now let's look at part 3, high-risk systemic screenings. We are going to rigorously analyze 5 specific danger zones for aging patients.
Danger zone number 1 is the gastrointestinal system. The United States Preventative Services Task Force explicitly recommends against routine colonoscopy screening for average-risk adults over 75. And the mechanical data clearly proves why. A routine colonoscopy carries a 1 in 500 risk of bowel perforation. For an older adult with thinning colonic walls, a tear instantly introduces lethal fecal bacteria directly into the abdomen. This triggers severe sepsis, requires an emergency laparotomy, and often results in a permanent colostomy bag.
But here is the truly shocking part. The severe danger often begins before the endoscope is even unwrapped. Take the clinical case of Margaret, a highly active, asymptomatic 78-year-old. The aggressive hyperosmotic gradient of the standard laxative prep physically pulled massive volumes of water right out of her bloodstream. This caused rapid intravascular dehydration and a lethal drop in her serum potassium levels. Without adequate potassium, her heart's electrical conduction literally failed, triggering a severe cardiac dysrhythmia and an emergency hospitalization. All of this purely from the preparation phase.
Danger Zone 2 takes us into oncology, where we are facing a massive epidemic of overdiagnosis. Studies out of the New England Journal of Medicine demonstrate that up to 40% of breast cancers detected by routine mammography in women over 70 are completely indolent. Yet, attaching the mere diagnostic label of cancer activates a wave of devastating interventions, like radiation that induces extreme cellular fatigue and aromatase inhibitors that actually cause chemical osteoporosis.
We are seeing the exact same iatrogenic tragedy in prostate cancer screenings. Look, an aging prostate naturally enlarges, which naturally elevates PSA blood levels. But this completely benign elevation leads directly to transrectal biopsies, procedures carrying a 5% risk of pushing infectious colonic bacteria straight into the bloodstream. Consider 81-year-old Gerald. a slightly elevated PSA resulted in the radical surgical removal of his prostate. To eradicate a mass that was biologically harmless, Gerald was left with permanent urinary incontinence and a total devastating loss of his personal dignity. Our third danger zone is cardiology. Routine cardiac stress tests generate a staggering 40% false positive rate in asymptomatic patients. Why? Because as the human heart ages, the vascular walls naturally stiffen, and the heart muscle marginally thickens just to compensate. The screening machine erroneously interprets this completely standard, age-related structural change as active ischemia, or oxygen deprivation.
These false alarms are critical because they mandate highly dangerous arterial catheterizations. Scraping an intravascular catheter against an aging aorta carries extreme risks of dislodging calcified plaque and causing a massive stroke. If they find a blockage, surgeons deploy a metallic stent. Yet the landmark ischemia trial definitively proves that deploying stents in stable patients does not prevent future heart attacks. It does not extend overall survival compared to conservative medical therapy. All it does is introduce the severe, lifelong hemorrhagic risks associated with blood thinners.
Fourth, let's talk about skeletal health. Routine DEXA bone density scans frequently trigger prescriptions for bisphosphonates. These drugs chemically paralyze osteoclasts, the exact cells responsible for clearing away microdamaged bone. This stops your natural bone remodeling entirely. Sure, the bone appears dense on an X-ray, but it's effectively petrified, creating brittle bones highly susceptible to atypical transverse femur fractures. True kinetic home defense, meaning rigorous physical balance therapy and eliminating environmental trip hazards, mathematically eliminates genuine fracture risks with zero physiological toxicity.
Let's move to our fifth and final danger zone, which builds directly upon our understanding of catastrophic vascular interventions. Routine carotid artery ultrasounds often detect asymptomatic, heavily calcified blockages that the brain has completely adapted to over decades. However, surgically intervening to scrape out this stable plaque carries an absolute 2 to 3% risk of mechanically inducing a massive stroke directly on the operating table. Tragically, violently clamping a stabilized artery disrupts the brain's highly adapted collateral circulation. As documented in the clinical data, a 79-year-old patient named Robert walked into a clinic completely independent for a so-called preventative endarterectomy. Due to the mechanical trauma of the surgery itself, he awoke with a massive ischemic stroke, permanently unable to speak. The medical intervention precipitated the exact catastrophe it was designed to evade.
This brings us to part 4, the symptom distinction, and knowing exactly when you must intervene immediately. We have to draw an uncompromising, crystal-clear boundary between hunting for invisible, asymptomatic diseases and executing rapid, life-saving emergency medicine. If you, or a patient, experience any active, acute physical symptoms, visible blood in the stool, crushing retrosternal chest pain, sudden unilateral weakness indicative of a mini-stroke, or unexplained weight loss, the biological mathematics instantly revert. In the presence of these acute symptoms, immediate, aggressive diagnostic intervention and hospital admission are absolutely vital to saving your life.
Finally, Part 5, the 4-question protocol. This is about actively defending your bodily autonomy.
To combat the automated inertia of institutional medicine during routine visits, you must fiercely protect your biological independence. You need to memorize and strictly enforce this defensive step-by-step protocol with your clinicians. First, ask, what exactly does this test look for and what is the required procedural cascade if an abnormality is found? Second, demand the morbidity data. What are the specific surgical risks of that treatment given my exact chronological age? Third, challenge the intervention bias. What is the verified statistical risk to my lifespan of doing absolutely nothing? And fourth, is there a non-invasive alternative like a stool DNA test that prevents physiological trauma? Forcing your clinician to answer these exact 4 questions breaks the cascade effect and demands true clinical restraint. Ultimately, protecting your biological independence requires a radical shift in perspective. Our advanced medical machinery will inevitably find structural flaws in every single aging body. Therefore, the most courageous, highly advanced medical decision you can make is often recognizing when an intervention is an error. We leave you with this final thought. Is the ultimate pinnacle of modern geriatric medicine mastering the profound, highly ethical discipline to know exactly when to do absolutely nothing? Thank you for joining this explainer. Protect your autonomy and always make informed clinical decisions.